I would like to invite Dr. Shanwa sir to proceed with the PG teaching program. Thank you.
Very good evening to all. Respected IAP, Alapura IAP, Alapura Krami Pediatrics President Dr. Sri Prasad, State President Josar, and Madam and other senior faculty. So today we are going to have another episode of this presentation. Who is the host? Please mute all.
Rashmi, please do the needful. Rashmi, are you there?
Sir, co-host alla.
Host alla. Shanwa sir ne unmute ചെയ്യണേ.
ഞാനല്ല ചെയ്യുന്നത് സർ.
co-host ഉണ്ടല്ലോ, TDMCH ആലപ്പുഴ എന്ന് കാണിക്കുന്നുണ്ടല്ലോ. സൂസി മാഡം co-host ആണ്, പക്ഷെ വേറെ PGs ആരും ഇല്ല.
ഞാൻ co-host ആണ്, മ്യൂട്ട് ചെയ്തിട്ടുണ്ട് സർ.
Okay. Thank you. Please proceed, sir.
Okay, so today we are going to have a case presentation. One of the case usually kept in our PG examination. So it is a one of the neurodegenerative conditions. So we are going to discuss in a way that is a common general pediatrician discuss such a case, not a neurologist view. We'll have a discussion on that. So our mentor is Dr. Susi. Madam, you want to tell something, or we'll directly go to the discussion by Dr. Kiran?
No, sir. Directly go to the discussion.
Okay. Over to Dr. Kiran to present. Kiran.
Sir. Sir, visible answer. Is it visible?
Visible. Audible also.
Good evening, all.
You can slightly raise your laptop so that you will be visualized. All. You are partly visualized. You. Okay. Now, okay.
Good evening, all respected teachers and dear friends. I am going to present a case of neuroregression. It's a case of 8-year-old 11-month female child. Date of birth 2010-2014. Informant is mother and she's a BA Economics graduate and history is reliable. Date of admission is 2/9/23 and date of examination is 4/9/23. Presenting complaints: child with global developmental delay with poorly controlled seizure disorder on multiple medications with daily 3 to 4 episodes of seizure from 1.5 year onwards. Now presented with fever for 3 days, nasal discharge for 3 days and cough for 3 days. And she also had a breathing difficulty for 1 day. Coming to history of presenting illness: child with developmental delay and seizure disorder, presented with fever. Fever started 3 days back, high grade, associated with rigor and responding to antipyretics, and again reappearing after 6 hours. Cough started 3 days back, initially dry type, later turned into wet type of cough. No diurnal variation, no positional variation, and no post-perceived vomit. Rhinorrhea, which was present, is a watery type, and history of regurgitation of feed present. And she was treated on OP basis for this complaint with oral antibiotic and salbutamol. Cough increased in severity for last 2 days, and mother noticed breathing difficulty in the form of fast breathing and chest ingoing. History of decreased oral intake present, and urine passed twice daily. And in last 2 days, urine output was decreased in quantity and urine also in high in color. And no bluish discoloration of skin, no noisy breathing, no skin lesions, and no irritability while urination. Child has been having abnormal jerky movements of bilateral upper limb and lower limb and staring look, which is lasted nearly 1 minute for 4 to 5 times per day. Had these 3 to 4 episodes per day from 1.5 years onwards. She is on treatment for this condition with oral Levipil, valproate, and clobazam. No change in seizure duration, frequency, or pattern of movements during this illness period. For this complaint, she admitted in TDMC. The parents' main concern was a respiratory illness, as the child is having continuous daily seizure from 1.5 years onwards. They are least bothered about this seizure activity. Coming to course in hospital, because of severe respiratory distress, child was admitted in PICU and started on O2 support, nebulization given, IV fluids in view of poor oral intake, and anti-epileptics were changed into IV in view of poor oral intakes, and antibiotics were also added. And child is improved after 2 days, and treating doctor told that child has pneumonia and oxygen level was improved and weaned off the O2 support, and the IV antibiotics were continued. Noticed bruises around the prick site and cannulation site during the hospital stay. No reddish discoloration of urine, no history of passing dark colored stool, no history of other bleeding manifestation, no history of vomiting. Some blood tests were done and found that some count was on lower side, and no treatment started for this condition and continuing all previous medication through IV routes. During hospital stay, abnormal movements persisting 45 episodes per day, and duration is still less than 1 minute, and no changes pattern of movement during this hospital stay also noticed. Since the child is a case of developmental delay and had events which started from 1.5 months onwards, I would like to start from the antenatal history onwards.
Okay, so far, what is your impression? So before going to the other part, so what is your impression so far?
Child is a case of a global developmental
That is that you are going to tell in detail later.
Yes,
That's good problem.
Now, child is presented with a respiratory infection and fever and respiratory infections. History of regurgitation of feed was present. Probably aspiration had occurred and developed a pneumonia.
Okay, that could be, but other possibilities they started as an upper respiratory symptom. Respiratory symptoms started as a fever, running nose. Therefore, you classically described as if an infection, upper respiratory infection going to pneumonia.
Yes, sir.
What the other possibility, because the child has got a primary problem, you can think that the other thing also. Okay, how is the severity now?
It's a severe respiratory distress because child is having fast breathing and also decreased oral intake, which lead to decreased urine output. So severe, it is a severe case. And she also admitted in PICU.
Mission PICU can be admitted anywhere. Okay, so the main problem is patient had hypoxia, isn't it?
Yes. Yes.
Needing some oxygen support. Patient has got sensorial changes so much so that patient is unable to feed, inability to feed, hypoxia. So both will indicate the patient might have severe pneumonia, somewhat severe pneumonia. We can't apply the even now we can apply this danger signs, since even if the age is more than 5 years. Danger signs of pneumonia can be applied everywhere, anywhere for a respiratory problem. So sensorial changes, hypoxia, okay, like for severe. Okay, then it could be a severe pneumonia, possibly aspiration pneumonia or secondary infection. Okay. Now we'll deal primarily with the our primary problem. Okay, go on with the primary problem.
Coming to antenatal history, married at the age of 22. Mother age at marriage was 22 and husband age is 23. Non-consanguineous marriage. Mother have no pre-pregnancy illness and spontaneously conceived after 3 months. No preconception folic acid was taken. Detected pregnancy by UPT after 1 month of missing period. And she was registered for antenatal checkup and done 5 to 6 antenatal visits. And blood group was B positive. Her height is 140 and weight gain during pregnancy was 10 kg. Coming to first trimester, scan was normal, no hyperemesis, no fever with rash, no radiation exposure, no vaginal bleeding or spotting. And viral markers done during this period, including HIV, was negative. Coming to second trimester, iron and calcium started, injection TT was taken, no hypertension, no diabetes, no polio or oligohydramnios, and quickening felt at 5th month. There was no history of increased or decreased quickening. And coming to third trimester, no GDM, no hypertension, no history of increased or decreased fetal movements. And weight gain was normal during this period, no bleeding or leaking period. Coming to natal history, it was a full-term LSCS. Indication was CS is due to non-progression of labor because of mother is a short primary, less than 145 centimeter, possibly maybe due to a CPD. And weight is 2.6 kg and child cried soon after birth. Coming to postnatal history, and PBF started after 1 hour and no difficulty in initiating feed was noticed. And Baby was sucking well at breast, and urine and meconium passed within 24 hours. And child was discharged on postnatal day 5 because of mother is admitted due to LSCS for completion of antibiotic. And child was thriving well during this period. And weight gain was also normal. And there was no history of neonatal jaundice during this period. So,
Okay, so we so far you just will start from the, or we'll finish this history and we'll go back to each slide.
yes, yes. Then mother noticed abnormal movements during 41st day, like uprolling of eyes, followed by staring look, and then 4 to 5 episodes of jerky movements of bilateral upper limb and lower limb, which is lasted for less than 1 minute. It was an unprovoked event and it was self-aborted and admitted in hospital on the same day for this complaint. Second episodes of abnormal movements of the same pattern, which is also lasted less than 1 minute and is self-aborted, which is occurred from hospital. There was no history of fever, no history of peer discharge, no history of trauma, no history of bleeding manifestation, no history of decreased feeding, vomiting, or decreased activity during immediate past period, and no history of abnormal body or urine or also noticed. EEG and MRI taken during this hospital stay, and it was found to be normal. And child was discharged on day 7 on medications. And this medication is continued for 6 months and was on regular follow-up. During this period, weight gain was normal. No feeding difficulties were also noticed during this period. Only exaggerated response to sound were noticed from 3 months onwards. Then antiepileptic stopped after 6 months. The child is seizure-free for 1 year and was on regular follow-up during this period also. Next episode of seizure is at 1.5 years. Till 1.5 years, the development was as follows. Coming to motor, and child has attained rollover by 4 months. Head control was achieved by 8 months and sitting with support by 9 months. At 1 year, 1 month, child had stand with support, and highest milestone attained was walk with support at 1 year, 6 months. Around 1 year, 6 months, the development quotient was 66. Coming to motor part, coming to fine motor part, reaching out for objects by 5th month, and with one hand at 7 months, transfer of object at 8 months. At 1 year, at 1 year, 1 month, child started picking objects from the floor. No history of scribbling reach, and the highest milestone obtained in fine motor is mature pincer graph, which is attained at 1 year, 1 month, and DQ was also around 66%. Coming to language, doing at 4 months, monosyllabus at 7 months. She started calling Acha and Amma at 1.3 years and not reached 8 to 10 words. That is at 1.6 years, DQ corresponding to 68%. And she attained a social smile at almost normal age at 1.5 months and recognized mother at 3 months. At 9 months, waist by and 1 year, 5 months comes when old. And does not, but she doesn't reach the milestone of coping parent task by 1 year, 6 months. DQ was also 66. It affected all domain, and hearing appears normal and was responding when called. Vision was also appears normal, following objects and identify parents and relatives. No history of difficulty in changing diaper, no history of frailness, and no history of slipping through the hands while holding an axilla till 1.5 years. No unsteadiness in walking, no abnormal movements of the trunk, and no abnormal hand movements noticed during this period. Then next seizure happened at 1.5 years, same pattern, which was also an unprovoked event, which is lasted less than 1 minute. For this complaint, she was admitted and advised to and video EEG was taken, and she advised to continue the Levy. After these episodes, notice that loss of the obtained milestones were noticed. Immediately after this 1.5 years seizure, there was no word output after these episodes, and interaction with parents is completely lost, and no maintaining eye contact with parents, and not holding anything in the hands. But she was responding to calls, but she could walk with support, and head controls was also present. Then walk with support gradually lost after 3 months of this event. The child was able to stand with support till 2.5 years, and after which that also lost. Head control was also gradually decreased and lost by around 3 years, and child became completely bedridden by 3 years. And physiotherapy started at 3 year, 1 month in view of stiffening of upper limb and lower limb. After 3.5 years of seizure, 3.5 years, seizure pattern changed. That is, semiology is deviation of angle of mouth, followed by uprolling of eyes, and there was a posture. Instead of jerky movements, now it's came like posturing of upper limb and lower limb. But jerky movements also present during some events. These movements were continuing like 3 to 4 episodes per day, and the duration of each episode was also less than 1 minute. No abnormal eye movements noticed, squint present, no deviation of jaw, no deviation of angle of mouth, no history of poor pooling of secretion in mouth, history of difficulty in swallowing liquid present, no history of swallowing, no history of difficulty in swallowing solid present, no abnormal tongue movements also noticed. No history of fever, irritability, or ear discharge, no history of diurnal variation of weakness, no history of abnormal movements of hands, body, and eye, no history of hair color abnormality, no history of skin changes, no history of abdominal distension, no history of any abdominal surgery for hernia, no history of rapid increase in head size or no decrease in head size noticed, no history of abnormal smell to body and urine, no history of hyperpigmentation to skin, no history of recurrent vomiting, poor activity, or no history of documented hypoglycemia, no history of constipation present during this illness period, no history of yellowish discoloration of skin and eye, no history of forward or sideward bending of spine or other skeletal abnormality, no history of teeth abnormality, no history of oral thrush or no history of recurrent infection, no history of abnormal hair texture also, no history of prolonged fever. At 6 years, she was admitted with some abdominal pain and distension, and some surgeries done. Possible diagnosis was appendicitis with some perforation in the intestine, and she was ventilated for 12 hours after surgery and developed pneumonia, and it's resolved and she discharged on day 8. After 4 weeks of the surgery, history of not passing stool present and vomiting started and abdominal distance present. Again, a surgery run, and she was improved after the surgery and discharged after 7 days. After this period, she stopped physiotherapy. After the surgery, there was for this physiotherapy stopped for a period and developed bilateral ankle contracture. Sorry, and detected hypothyroidism during this period. And she was started on thyroxine, and it also given for 1 year and stopped in view of normal. At 8 years, she was admitted in view of fever and seizure. EG and MRI was taken, and that was both were abnormal. Now the child is completely bedridden, can roll over, can't hold anything in the hands. She has no word output, but she responds to call by turning head and recognizes the family members by sound. Bowel and bladder control not active. Now daily seizure present, 3 to 5 episodes per day. And she had also decreased sleep and constipation present, no bed sore. She's using CP chair and CP stand, no using any special kind of bench. Coming to development.
Okay. So far from the history, what is your impression? We'll start from here and go back. So what is your impression regarding the so far history?
Child with uneventful antenatal period developed seizure on 45th day. Till that 45th day, social smile is attained. And after that seizure, child was sent down home with oral medication and was weight gain and feeding pattern was normal. But there was a developmental delay till 1.5 years, affecting almost all domain. It's around 66%. After around 1.5 years, she had got again a seizure. After that, there was a loss of already attained milestone present. Immediately, it is affected mainly in the cognition, vision part, and language. And after 1 to 2 years, around 3 to 3.5 years, other motor milestone also affected, like standing with support and head control is gradually lost.
So what is your impression?
Probably a child with a case of a neuroregression.
So what was the history of obtained milestone? Was a child normal before the regression onset?
Child actually at first seizure at 45th day, child was having social smile, was normal around that period. Weight gain was also normal. But before second seizure happened at 1.5 years, child has having some developmental problem and which affecting all domains. And development quotients around 66%.
Just a slowly attained milestone. So the case
Slowly
of attained milestone. So what are the ways by which a neuroregression can present?
Neuroregression present with loss of attainment of milestone, either in affect
Mainly three ways.
memory.
Mainly
Sir?
three ways. Mainly three ways. Number one is a perfectly normal child developing regression. So here it is another way. So to start with itself, there was a delay in attaining of milestone, but there is definitely some milestones were attained up to 66 from DQ. From where? From there, regression has happened.
Delayed development and delayed development and followed by regression, then episodic regression with stepwise deterioration.
Okay. So these are the ways that it can present. Here it is slow regression that has happened. Okay. So which domain is affected mainly?
First thing was lost is language, cognition, and vision also affected.
There are more than one domain affects. It's somewhat global affection, isn't it?
So,
Okay. So in that case, what are the? Is it a predominant gray matter or white matter affection?
it is likely to be a gray matter because of cognition, memory, language.
So what are the difference between in the history? How will you differentiate between a gray matter versus white matter? From the history,
matter,
and the history.
Gray matter usually present with history of seizure will be the
age of presentation of gray matter disorders.
Early age of presentation.
Usually early age less than 1 year or 6 months, like that will be the age of presentation. Then the major manifestations, as you said, seizure. Then
Seizure, cognition, language.
okay, so cognition, mentation, and also very much affected. Then,
White matter usually present with the long track site, spasticity, and
okay.
involvement is around after 2 years and on MLD and ALD. Usually,
Okay. What about the eye manifestations?
usually optic atrophy is seen in the case of white matter, and retinal changes is seen in the case of.
Both can present as blindness, but the etiology for blindness is in both conditions is different. Okay, any other difference? Then the others are in the clinical examination finding and also investigation. So these are the main findings. Can you tell one regression where it's predominantly affect motor milestones?
MLD and ALD predominantly affect.
Okay, only motor affection mainly, even though it is will not consider the degeneration, it looks like attained milestones are lost in case of myopathies and like conditions. DMD, vision muscular. It is not a primary white matter or gray matter disease, but there is a, we can consider this. Okay, which is a condition where there is isolated language regression occurs. Isolated language regression occurs.
Landau-Kleffner seizure.
So following Landau-Kleffner problem.
Stroke involving the which involve the.
Okay, in Landau-Kleffner syndrome, you can have isolated language. So you should think of other possibilities also whenever you are getting thinking all those things. Okay, so you started from the initial slides, isn't it? Is it from beginning? Slide, Sean.
Yes.
Next slide. Next slide. Okay, so it's so what is importance of consanguineous marriage for you?
IEM.
Okay, so as a part, we are now dealing generally. So IEM, autosomal recessively inherited conditions can have. What is your patient's age is patient sex is female child.
Female child.
What is the importance of female sex for a neurodegenerative condition?
Rett can occur in female child.
No, you should think of Rett syndrome. And again, the age manifestation is around 1 year. So like that you can consider. So you should tell there is abnormal movements. No abnormal movement is there. Whether it is present or not, you have to highlight. Or any typical rocking movements or some hand wringing movements is not there, you have to highlight. So I think it was not mentioned. Okay. Then these things are over. Okay. Okay. So what are the infectious causes of neurodegeneration?
It can occur in HIV and encephalopathy. HIV, chronic HIV and encephalopathy.
Okay, HIV encephalopathy, progressive rubella encephalopathy, SSP. These are the infectious infectious etiology of measles. So you have mentioned about that's why I asked, because you have mentioned there is their patient mother is HIV negative.
HIV
So
negative.
that is important. So that is your HIV. And so what's the age of presentation of HIV encephalopathy? Is it fit for your page if it was positive?
No. It will take usually after infancy.
These are all terms, 1.5 years only.
1.5 years.
So you can have that also. The age of presentation is not strictly against. So you can consider that also. Then, okay. Okay, next slide. So you said hearing appears normal. What is important? So hearing for you as far as neurodegenerative disease is concerned.
In certain storage disorders, hearing can be abnormal, like MPS. And also it also can be affected in white matter disorders, long practice.
So it can be a hyperacusis or maybe
Hyperacusis.
So you should think of both either way. What are the conditions? The hyperacusis,
Tay-Sachs, Sandow,
Tay-Sachs disease can present us,
hyperacusis.
and also we can have crabby occasionally. These are the two conditions that is mentioned with hyperacusis. So deafness mainly in case of mucopolysaccharidosis, you can present us deafness. Then comes vision. Okay. Next slide. Next one. Okay, so there is no paroxysmal worsening condition has not been noticed, isn't it? Okay. Proceed. Okay, why should I ask about fever, irritability, ear discharge?
So it's maybe a CNS infection like meningitis.
Chronic infection. You are not considered as a chronic infection.
Infection.
Even tuberculosis. Previously, when we were students, we used to have chronic tuberculosis as a manifestation degeneration can happen. Then diurnal variation, I should ask.
Diurnal variation, some case of Dopa responsive Sagawa, like that illness, may also present with seizure and tone abnormality. In
Abdominal hand movements. Why do you think of abdominal hand movement?
As a part of Rett syndrome or a tremor in case of beetle deficiency.
We can specifically tell hand wringing movements or like that.
Yes.
We should specifically tell.
And tremor in case of vitamin B12.
Okay. So what about the hair color abdomen? Why should I ask about
either Menkes kingi or phenylketonuria? A part of chronic malnutrition, vitamin B12 deficiency.
okay.
Can also
Vitamin deficiency. So many conditions can have hair abdomen. So you should ask about abdominal distension.
In case of storage disorder like
Megaly as a part. Okay. Surgery for hernia.
MPS and all present with abdominal and inguinal hernia.
Okay. So what are the conditions with the large head, increased head size? Genetic condition.
MPS can have an Alexan.
Okay. So usually you can have as associated with the other gray matter disease with the large head. Usually we'll differentiation is gray matter disease will have small head versus large head. Which gray matter disease has got large head?
Gray matter, large head.
Tay-Sachs disease can have Tay-Sachs and large. Okay, like that. Then decreased head size, you said gray matter diseases. You have an abnormal smell for this one. Hyperpigmentation, what are the condition issues?
Either in case of adrenoleukodystrophy or of beetle deficiency.
Okay, so you should better to tell suggesting this condition so that this questions can be avoided. So we are asking. Okay, next. Vomiting, poor activity, hypoglycemia. Why? Which
Constipation for thyroid.
Okay, so you can consider Leigh encephalopathy also can have vomiting, hypoglycemic episodes, and worsening, paroxysmal worsening. Okay, Eloise, skin and eye.
Part of galactosemia, in tyrosinemia, Wilson.
Okay, Wilson, will you consider this a younger age group?
No. Usually neurodegeneration on the adolescent period in Wilson.
Okay, so bending spine. Okay.
MPS, and it also occurs as a part of this.
Youth abnormality, I should ask.
In MPS, widely spaced in a hypo-forage syndrome like hypodontia, hypomyelination, hypogonadotropism.
Okay.
Oral thrush in HIV, recurrent infection HIV, abnormal hair texture in giant axonal neuropathy. prolonged fever for crabby.
Okay. So you have talked in detail about all those things. So you have ruled out each one. Okay, then we can proceed. Anybody wants to ask or highlight any? Purushottam sir unda?
It is well presented and discussed. It's difficult. I would have suggested the presentation the other way. It's also okay. Rather than too much of spending of time for this at present admission, you could have started from the beginning.
So
That's another method of presentation that would have been much better.
directly from
Okay.
At the end, elaborating on this, because this particular episode doesn't have much for the this contributing to this case discussion. Actually, that's all. Wait. Oh, this is also okay. When during the regression for the other people, as Dr. Sandava said, it should be stepwise. It's a developmental delayed problem. First thing, is it a regression or a developmental actual delay? In this case, regression. Second thing, is it global or one field only? It's more than one field. And then the most important thing, from what point of time onwards? If it is a very early, child is now surviving at up to 8 years. That's a problem, because whatever regression which we know starting so early, usually they'll be eliminated early. Surviving up to that is a little unusual. So that points towards a pattern Dr. Shanavas pointed out. Actual regression started a little later as a stuttering type of course, not that severe pattern, even though it was an onset early. That type of presentation is the thing. And in any other situation, if it is a little older age group, when you answer it's a regression, it's not only the neurodegenerative disorders, other NDs also should come. And Dr. Shanavas already pointed out the infections, low virus infections is one of the possibilities. Other possibilities, again, you have described nutritional deficiencies, some of them. You already described the B12, but there are other, especially there is another DD here, epileptic encephalopathy situations. So there are a few of these micronutrients responding type of. Some of them respond to biotin, some of them respond to high dose of vitamin B12, like that. So there is a treatable entity, few of them rarer also. So nutritional deficiencies, infections, and sometimes toxins also. So in this case, almost all these are out, because such an early onset is unlikely for a toxin to be, or for another infection to be responsible. So one of the possibilities, epileptic encephalopathy is a like situation. Another is few of the same deficiencies situations. Actually, it's not deficiency situation, vitamin dependent situations, where it may be a coenzyme which will be having some beneficial effect. So otherwise, all the discussion, I don't have much to contribute, Shanavas.
Thank you, sir. So, Dr. Kiran, so I am telling that what is pseudo-regression? Is it a pseudo-regression for this patient? So what are the conditions which a CP that mimic a regression? What are the causes?
In case of uncontrolled seizures,
Okay.
it can cause pseudo-regression. In case of certain conditions which involve the joints like pain, arthritis, that can also cause pseudo-regressions. Hydrocephalus.
Progression of the hydrocephalus. Progression of the hydrocephalus. Previously, hydrocephalus is progression in a CP patient can go. Then giving anticonvulsant. So patient having anticonvulsant
medications.
Then patients in extrapyramidal or some abnormal movements, worsening of the, with the CP is usually associated with abnormal movements. So that may go on movement disorders, co-infection. So coexisting, all those can lead to pseudo. Whenever there is a CP, when the milestones are very much low, there may be confusion whether it is a primary regression versus static disorder. So on these causes, you have to think of when there is. Okay. Then I think we can progress.
One more point. Now we point out, already you have point out, in any patient where there is a progressive decline of the course, we'll be considering all the central neurodegenerative disorders. But if it is an isolated motor problem only, but progressive deterioration, we need to consider peripheral. Actually, there are also progressive disorders, HMSN, the peripheral nerve progressive disorders, muscular dystrophies are progressive disorders. Actually, it's not the central nervous system neurodegeneration. There is a possibility of a motor unit-wise progressive disorders are there. If it is only isolated to motor regression. And one point, the importance of what is happening during an episode of infection. So in this case, there was a seizure already. Is there a neurological process which is aggravated during the infection? Each of the episode that worsens and in between. So that sort of a phenomenon is useful because there are a lot of situations where you are finding it difficult to answer whether it is a degenerative disorder at all. Especially a case like this, it's very slowly progressing, surviving up to 8 years. The infection, how it worsens or alters, affect the course. Unexpected worsening of the neurological problem indicates of these neurodegenerative. Okay, go ahead.
Coming to diet, there was she can swallow solid food and some chewing movements present. And for liquid food, there was much difficulty and there was history of regurgitation of feed also present. Now she's not on any diet restriction or not on any modified diet. No history of pica, calorie deficit of 300 kilocalorie, and there was no protein deficiency. Diet is deficient in iron and calcium.
What is the importance of pica for you?
Lead poisoning can be caused.
So one of the etiology we have thing is degeneration. Can have lead poisoning. Can lead to lead poisoning. Okay.
And difficulty for liquids, so mainly for swallowing liquid is also present.
Okay.
Immunization, immunized up to age and all vaccine is taken. No AEF. Family history, no history of seizure, developmental delay, mental retardation, or no neonatal death in family. So
what are the X-linked inherited neurodegenerative disorders?
Adrenoleukodystrophy.
That is present both. ILD can be both X and autosomal recessive. Okay. That is not the first thing that you should tell.
Under MPS okay. Under.
Okay. Then can cause so many conditions. You said there will be hair changes, Menkes
skins.
Okay, then it could be due to Felicis-Merzbacher can be. So many conditions can have actually recessive inheritance. So when their family history is then when you maybe ask some questions like that. Okay.
Coming to socioeconomic status, she's having disability certificate of 100% and UDID present, and she's receiving 1,500 monthly pension, and she's registered in Niramaya scheme and as a BPL card holder, and she also belong to lower middle class family. Procedure, sir.
Okay, proceed.
Coming to examination, general comment, lying on the bed with elbows and knees flexed, moving all limbs. Now child is on O2 prongs with the contracture deformity at bilateral angle. Coming to vitals, pulse rate is 120, 112 per regular and rhythm, and BP is 110/62, and respiratory rate is tachypnea is present, and periphery is 1, CFT is less than 3. Coming to general examination, pallor is present, no icterus, cyanosis, clubbing, lymphadenopathy or no edema. Coming to head to foot examination, head size appears normal and shape. There was a flat occiput, maybe due to prolonged lying on this occiput. Hair color and texture appears normal, no alopecia. Eye bilateral prominent eyes, no cataract, no corneal clouding, no carefree. Ear is low set and nose is normal.
Will you get alopecia?
Usually in pyridoxine deficiency. Biotic. Sorry.
Okay. Where are the conditions is cataract and degenerative disorders?
Cataract is a part of galactosemia. Can also can occur in certain muscle from myotonic dystrophy.
I didn't get it.
Galactosemia,
I think I got
Fabry's disease,
Fabry.
Wilson,
Wilson, Lovey.
uh,
Okay. How many conditions can have cataract? So just since you mentioned it, I asked. Cornea also you can tell. Okay. Then
no facial dysmorphism, no coarse facies like under, no neurocutaneous marker, oral cavity carries tooth present, no hypodontia, no widely spaced teeth, no gum hypertrophy, no palatal petechia, tonsils normal. Tongue normal in size and
the condition with large tongue and neurodegenerative condition.
Storage disorder, hypothyroidism, MPS.
Okay. MBS, POMB. So many conditions can have GM1 gangliosidosis, can have large tongue. Okay.
Neck is normal, short neck is seen in MPS and all. And no hyperpigmentation in case of beetle adrenoleukodystrophy. Nail is also normal. Chest scar of skin biopsy is present. No other skin lesion is seen. Abdomen, no distension. And hypertrophied scar of surgery present at abdomen. No hernia noticed. Spine is normal, external genitalia normal. Hip, no asymmetry seen. And Galaxy's crest is normal. Foot bilateral fixed contracts present. No subcutaneous nodule. SMR staging is pre-puberty.
What all condition can have subcutaneous nodule?
Fabry's disease.
Okay. Fabry's disease is the prototype condition. Can even have Fabry's disease, can have angiokeratomas like conditions. Okay. Proceed.
Coming to anthropometry, weight is 21 between 3rd and 10th centile, and height is 120 centimeter between 3rd and 10th centile. BMI is 14.2, and head circumference is 51.5 for an 8. It's normal for an 8-year and 6-month-old child.
So your patient is getting adequate calorie. You said calorie is adequate. Then there is weight is only 21 against.
No,
9.
calorie 300 kilocalorie deficit. Sir.
Okay, 300. Okay.
BMI is on lower side. Considering
21 kg is low.
coming to respiratory system examination, upper respiratory.
I don't go to the examination. I'm happy that you have mentioned few of the important point which all the postgraduates should be presenting when you get a case of developmental delay, dependent, disabled situations. The government programs they are in the scheme. Niramaya scheme is the mother's caregiver burden you have mentioned, whether she's employed, you have mentioned. And one more thing, whether the pension, scholarship and other scheme they are getting from the. So all these things are important because of a public health aspect. How much is the benefit from the government they are getting? So because overall management of this patient is our responsibility. So that part should be stressed. Then in the general examination, you just take that first photo and the second photo. There's an interesting thing. The first photo, this first photo. See the posture of the upper limb. When you see usually in a white matter degeneration and things like that, the spasticity will be dominant. You see the upper limb position. This is not the position when the human features are there. So the position of the abducted, extended type of the upper limb position, a bit unusual. And what I'm interested is about the hands. So you didn't describe about that. So what is the hand and fingers and position? Because in the general examination, there are two aspects. One is, is there a clue towards the basic problem? Second thing, what are the results? So in the general examination, all these subtle points in the general examination for all the possibilities. Is it a static disorder, progressive disorder? In a case of progressive disorder, what are the clues coming from head to foot? So all those things are important. And the effects and disability part and the problems which has happened because for the management, they are important. So what about the fingers and hands? Because there are a lot of deformities and the finger part, because orthopedic correction may not be that relevant in this case where it's a neurodegenerative disorder, but the same case when you're having a static disorder, something can be done, though hand part is important. When you see the lower limb again, there is a spasticity, flux, plantar flexion, angular contraction. We are interested about the upper part also, the hip, because that also is the part of deformity assessment, and the chest and the spine part also. So what about the spine part? Deformities involved with the spine, sideways bending, about the rib crowding, all those things, because that also will contribute to the complications like respiratory. So crowding of the ribs, bending of the spine, and that part also. So these are all deformity assessment. Is it a soft tissue level only? Is it a bony level? So what are the management options available? May not be in this case, but a similar case. One more point in a regression, Shanavas sir was pointing pseudo regression. There are some of the conditions which you may consider regression. One thing is the hip disorders. Development up to 10 months, 1 year normal. And from that point onwards, it's not losing milestone, but not gaining. So bilateral CDH situation. So it's a totally different thing, neuromuscular problem. And sometimes that sort of an arginase deficiency and all also present like that. That's a regression part. Anyway, okay, good presentation. Go ahead with the CNS part.
Coming to examination of respiratory system, upper respiratory system, there was nasal
There is not much points in upper respiratory system.
bilateral crepitations presence.
We go to the neurological exams.
Environmental functions, he was awake and not interested in surrounding. Memory, intelligence, speech cannot be tested. No emotional importance not tested. Cranial nerve, 1 not tested. Second, acuity field of vision, color vision not tested. Fundus, there was doubtful retinary pigmentary changes present. We take expert opinion from ophthalmologist also, and they also told like there was no definite optic atrophy, but some changes are present. And 346 no ptosis, no.
What are the fundus abnormalities you expect in a case of neurodegenerative conditions?
In white matter disease, we can see optic atrophy.
What type of optic atrophy?
Primary optic atrophy.
How will you differentiate primary versus secondary optic atrophy?
Primary is clearly white with loss of margin. In secondary, there is these margins are irregular and long.
Yes, color is
very pale.
Dusky white in a case of, or dirty white in a secondary. Irregular margin. Have you heard of Kustenbaum number?
Artery numberless.
It will be very much reduced in case of secondary optic atrophy than primary optic atrophy. Both are okay. So that is then optic atrophy. Then in white matter, gray matter.
Retinal changes.
What is the retinal range usually seen?
Pigmentosa and mitochondrial disorders also.
Okay, retinitis pigmentosa can be there. And we really get cherry red spot.
Tay-Sachs.
Same other 5 conditions or 4 conditions or 2 conditions of cherry red spot other than Tay-Sachs.
Tay-Sachs, Sandoff.
Both are similar condition.
Sialodosis.
Sialodosis, Niemann-Pick disease.
1 and 2.
Okay, DM1, 2 and 2. Okay, so some conditions. We should know some of the conditions as a PG. Okay. Then what are the other eye findings that you expect other than fundal changes? And we said there earlier we said about some other findings. Cataracts,
corneal clouding.
Then
nystagmus can be there.
Okay. Okay, go.
Coming to 346, squint present. No ptosis, no eye movements were normal. Pupils bilateral and equally reactive.
Okay.
5th cranial nerve, no deviation of jaw. Jaw jerk present. Corneal reflex presence. Sensation of face not tested. 7th cranial nerve normal. 8, hearing appears normal. She was responding, turning head while falling and responding to ringing bells. 9 and 10 gag.
How is he ringing? How is he responding? How is he responding? How is he responding?
Turning head.
Those sounds.
She is also recognizing mother's voice also.
Okay.
9 and 10, gag reflex is exaggerated. There was difficulty in swallowing liquid present. 11 and 12, 11 cranial nerve was no. 12, no tongue fasciculation, no atrophy.
Can tell hypertrophy also. Tongue. Hypertrophy also. Besides GM1 gangliosidosis. So many conditions can have tongue hypertrophy. Tongue, big tongue. Okay. Okay. Any,
Arun, about the in the history also, the lower kind of things, you need to go a little more in depth about the feeding. The feeding part, it's not enough to say that there is feeding difficulty, a little more, because feeding is one of the most important difficulties in the functional derangement, where the mother has to sit with the patient for a very long time. How long it takes for the feeding? What is the type of difficulty? Is it, you said there is a liquid swallowing. So the chewing, is it happening, or semi-solids only or liquid only? Is there a, what is the problem? Basically, swallowing, is an aspiration. How much time it takes for the feeding? That part is important. In the ocular part, one thing is the sideways gaze and gaze problem, because one of the this is neuro type of Gauchers. In this case, a bit unusual, where the neurological, the gaze problems will be there. So that's important. Okay.
Have you heard of any classification regarding feeding? Just like gross motor function classification for motor milestones.
There
There is a classification for feeding also. Okay. Go ahead. Okay. Just all the points, sir has already said. Those points are graded and given as count for grades, just like motor milestone. Okay.
Coming to examination of motor system, bulk bilaterally comparable, symmetrical, and mild wasting is noted in the lower leg. And on the inspection, upper limb adducted and at shoulders, and hand is kept in midline. And coming to lower limb, it is abducted and externally rotated with flexion at knee and bilateral fixed ankle contraction. Palpation and upper limb muscle, it is slow to hard, and lower limb it was firm. Coming to passive movements, hypertonia catch is seen in the present in the upper limb, and hypotonia is noticed.
The position of the lower limb, you said it's abducted, externally rotated. A bit unusual.
It's not external rotated. Almost Indian rotation.
It's a bit unusual because that is against the basics. Because in a patient like this, what is the basic problem of the neurological thing? Whatever, gray matter or this thing, it's not a motor unit problem. So there will be always the higher tone for the adductors and internal rotators. If there is an abduction, that goes in favor of a hip pathology superadded on to that. Not neurological. You heard of Windswept deformity, fracture of these things, dislocation. Then only you'll get that posture of the hip. Otherwise, always the neurological problem, unless it's a peripheral, it will always be adducted internal rotation. That tendency will be the dominant thing. So your description of external rotation abduction goes against the basic problem.
Coming to power, there was grade 3 in upper limb and lower limb. No involuntary movements noticed. Coming to reflex, corneal and conjunctival reflex normal, abdominal reflex absent, anal reflex not tested, and plantar is bilaterally extensor. Coming to deep reflexes, jaw jerk present, biceps bilateral, biceps 3+ in bilateral upper limb, triceps 3+, supinator jerk also in 3+. Knee jerk is 3+ in bilateral lower leg, no patellar conus. Ankle jerk is 2+, and no conus is noticed. Coming to primitive reflex, snout, grasp reflex, and palmar-mental reflex present.
Here again, there is a chance of examiners not agreeing with your findings. You said the angle jerk is
It's much
2+.
higher.
and you already committed that's a significant fracture. And the position of the foot doesn't seem that you can easily elicit the plantar also. So there can be an argument. Could you elicit the angle jerk? Definitely, because I don't think. Shanavas, what do you say?
There is so much angle contraction just shown. It's almost equinus in the form. So dorsiflex for an angle jerk, it is difficult. So you have elicited, you got it. If you got it, no problem.
Got it, sir.
Okay.
Sensory and autonomic cannot be tested. Cerebellar signs can be tested. Skull normal, spine normal, peripheral nerve thickening.
One more point about the angle jerk. What is the importance of angle jerk in other situations? Suppose forget about there is no deformity, there is no contracture. What is the importance of this angle jerk in a neurodegenerative problem? Not in this case.
Peripheral nerve involvement.
Very good. Because in the basic approach, especially when it comes to a white matter degeneration, then comes with the peripheral neuropathy, without peripheral neuropathy. So angle jerk presence argues against the group with peripheral nerve neuropathy. So that is the usefulness.
Coming to other system, GIT, no hepatosplenomegaly, liver span is also normal. Coming to CVS, no cardiomegaly, no murmur, CVS also normal. Coming to diagnose.
Can summarize your quickly in five words, 5 sentences, the history and short finding, then tell the diagnosis.
8-year-old 6 months child with uneventful antenatal period, history of first episode of seizure at 45 days, followed by delaying attained milestone till 1.5 years. And she has with the history of loss of milestone after 1.5 year episode of during seizure after 1.5 year episodes.
We can tell like this, till 5, slowly attaining milestone till 1.5 years, develop predominantly seizure, cognitive abnormalities, higher function, higher intellectual dysfunctioning, then have visual abnormalities. So that is going and without much tone abnormality to start with. Only late part we have, so that will give you flow everything, summarizing all points to some diagnosis you want to tell. Then go for the examination. Cranial nerves are higher function, cranial nerves, motor systems, and finish. Okay. Findings also you can summarize and finish.
Manos.
Okay.
GDD, spastic quadriparesis, neuroregression, neurodegenerative disorder, most probably gray matter involvement, epileptic encephalopathy, pseudobulbar palsy, bilateral ankle contracture, constipation, sleep problem, gastroesophageal reflux, and visual impairment. Now admitted for aspiration pneumonia. Okay.
So I think if I will better prefer the okay. So you can go like this with the global development delay, spastic quadriparesis. So these two will give the examiner think that you are going to tell cerebral palsy as a diagnosis. So you can start with the neuroregression, I think. Sir, what about Purushottam sir? What do you think?
In this case, in the diagnosis, you're mixing up epileptic encephalopathy with a neurodegenerative. There are different conditions, Arun disappear, though. Arun, in a case like this, epileptic encephalopathy is a totally different group of disorders. So you need not mix up that epileptic encephalopathy here, I think.
Can even tell us a DD.
That's a DD better. Strongest DD. Okay. Don't mix up both this thing. Neurodegenerative disorder, okay. The other one.
You start with the neurodegenerative disorder, most probably gray matter involvement, gray matter, predominant gray matter. So now it is both affected. So you can go for predominant gray matter involvement with the functional classification that is spastic autopsy, that is GMF 4. And global. Then differential diagnosis will be epileptic encephalopathy. Problems are pseudobulbar palsy, contracture, constipation, sleep problems. So these problems you have to highlight, because as a pediatrician, your primary management is only on these things. You will be seeking the help of neurologists for the other management. So problems you have to highlight, definitely. Okay, so we'll take one by one. Why do you say neuroregression? We have already discussed why you consider this neuroregression. Why you consider gray matter disease also, we have already discussed. So of the gray matter disorder, what all things will you consider here? What are the gray matter disorder you think? PD 1, 2, 3, 4.
Neuronal cerebral lipofuscinosis only.
Okay, neuronal cerebral lipofuscinosis. Then will you consider late onset ASAC?
Can be no.
So the neurogen is there is no organomegaly. So visceral type of neurogen disorder is out. So you can see only CNS type of, with the peripheral neuropathy also you say we have out. So because you got the ankle reflex, peripheral neuropathy, white matter disease also. So predominant gray matter, you can consider late onset Tay-Sachs or neuronal cerebral lipofuscinosis. Sir, anything else, sir? You can consider.
Tay-Sachs need to be considered, but the problem here is you can't explain the time of the little surviving. It's onset from very
surviving is
8 years, a bit unusual. It's not fitting with the Sandows also. Sandows won't have onset so early. So that is a point which is finding it difficult. So that's why you are going for the other one. That is a neuron. That is that comes the first possibility. Otherwise, common thing always in the gray matter degeneration starting early is the classical of a Tay-Sachs. And the head circumference is not affected. Hearing is normal. Fundus is okay. There are so a lot of points against that one. So neuronal side, this comes as a number one, I think.
What is Batten-Mayo disease? What is Batten-Mayo disease? Same thing. So it's a late onset neuronal cerebral lipofuscinosis, Batten-Mayo disease. Okay, so you are considering any differential diagnosis? Epileptic encephalopathy is a difference in what is the epileptic encephalopathy?
Recurrent occurring of epilepsy without which is difficulty to control on
okay. So it is a malignant epilepsy with the developmental delay and other that leads to regression of the milestone. That's epileptic encephalopathy. So many conditions that will come under. It's a common name for so many conditions. Okay, so that's also you can consider. Sir, any other DD we can consider here, sir?
I think neuronal cerebral lipofuscinosis is one of the prominent, and Dr. Anavas was pointing out there are few entities. It's not a one entity actually. The Batten-Mayo, Jansky, Blilskowski, another name I remember. There are a few of the cases where there's a combination where the anti-horn cell also can be affected. Some of the situations it can be a combination of the upper thing and the lower thing. The tone can be variable. There can be features of these are typical things. Okay, the epileptic encephalopathy is there are certain criteria when you consider. It's a usual type of epilepsy, a type of inheritance pattern, a particular type of EEG, a particular response to drugs, all the combinations in a case of one particular epileptic encephalopathy. There are many disorders which you go and read about it with an onset at different times, different patterns. Many are there. So here also there can be a regression from one particular point of time. So that's why you consider that as a DD.
Okay, so how are you going to manage the same? We'll go to the management and for the investigation.
One point, Arun.
Sir.
in this case, Dr. Shanavas rightly pointed out, we are discussing from a pediatrician's point of view, and we are closely answerable or close relation with the patient. So there is nothing like nothing can be done for this patient, just let it die. That should not be the attitude. We should be taking care of this patient also, just like a static disorder CP. All the assessment for the functional derangement. What is the functional derangement in the motor? What is the functional derangement in the manipulation? What is the functional derangement, this and that? And what I can do for this child to have a better life. And all those questions will be asked if it is a pediatrician examiner. So you should have answers to alleviate his agonies and the parents' agony. So in the evaluation, a lot more things are there about the mother's consideration for the child, neglected child, how much care he is getting, infection, infestations, all these will be asked from the pediatrician's point side, not as a neurologist going for the UNM, LM, the other science and this science. So there are a lot of things which you can do for. That's why I stress about the programs, national programs also. Okay.
First thing is, as child is having pallor on examination, I would like to and
They'll
also
came with this.
addressing
They'll came with this aspiration pneumonia. Your diagnosis aspiration pneumonia.
aspiration pneumonia. So feeding part also to be addressed, like tube feeding or feeding gastrotomy.
First thing is you should go for an X-ray.
Sir, that
Okay.
part we have to take the X-ray.
Okay. So I really expect the pneumonic patch in the case of aspiration pneumonia.
And upper lobe, usually, right?
Okay. Okay. It's usual site of upper lobe collapse console can be there. So you treat it for what antibiotics?
Crystalline penicillin can be used.
Okay. On penicillin group of antibiotics with the glycosa will be. Only penicillin will not be, may not be. Okay, that will be the antibiotics. Then you should manage the feeding. What are the management you can give feeding?
Tube feeding can be advised. If a recurrent problem is there, we can also advise feeding gastrotomy.
Okay, so PEG is a one, and nowadays it is widely being used. So I think this patient, when I was there, we were planning to put PEG in. We have a discussion with the pediatric surgeon. They were planning to do a feeding gastrostomy for this child. That is the most ideal. So especially when there is a repeated pneumonia. So it will tackle the feeding problem and prevent aspiration. Malnutrition and aspiration will be prevented by this. Okay. So otherwise you should give slow, steady, slow feed, thickening of the feed like that you can give. So prevent aspiration, more time for feeding like that. Okay. So feeding should be tackled. Number 2.
Next is sleep problem can be taken care with melatonin.
Okay. So many drugs are available. Of the most commonly used and least side effect is with the melatonin. You can give. That's a good drug for sleep. Then that is one problem that parents are often very much very much worried because they can't even sleep. They should be with the patient. Okay, so you better treat that patient. Are you giving this melatonin for this patient?
No, sir, not start. Not on melatonin. We started after admitting.
Okay.
And constipation, proper diet with fiber contents. And I will check also for thyroid status.
So sometimes you may again here also PEG, that is maybe needed. Some laxative polyethylene glycol may be needed.
Bilateral angle compensation test is fixed. Can be go for tendon lengthening procedure after discussing with orthopedicians.
Okay. So I think when a surgical procedure for this patient is, I think, better avoided because it is a progressive disorder. So you can better think of position splint and physiotherapy than going for a surgery. Okay.
In enrolling in her scheme so that drug cost can be reimbursed.
Okay. So regarding his primary problem, do you want to confirm or rule out?
Yes, sir.
Will you confirm?
He's having still seizures. Daily she's having 45 episodes.
What type of seizure he is having? What type of seizure is it?
Actually,
Infantile spasm or something else?
No, it was staring look with like myoclonic jerk.
So what is it? It's a myoclonic seizure, not an infantile spasm like this. Myoclonic seizure, your duration, you said is nearly going to 1 minute. So it may not be a true. Okay, it is only one single type of seizure always, not much.
No.
Okay, so which is the best drug for myoclonic seizures? You can go for sodium valproate. Levetiracetam is a good drug. You can go for clonazepam and other benzodiazepines are very good. What is a problem with when if you start the patient on clonazepam and other things?
Drooling of secretions.
Okay, there is salivation,
Metabolic derangements.
that can lead to aspiration and problem. So you should be very cautious in starting this one. Okay. Okay, then that is regarding they will be, it will be better managed by our colleagues. Then what about the do you want to confirm your, if you are seeing the for the first time, you want to investigate in which way?
MRI brain can next followed by genetic testing.
Okay, MRI genetic test. Okay, so those investigation. If there is some other, you go systematically depending on the condition. So skin biopsy and other things, other investigation can also be done depending on the condition. So it is mainly
suspecting NCL, we can go for skin biopsy.
Okay, biopsy, skin biopsy like that for neural like that. And nowadays everything is for genetic study, sequencing are going. NGS is the last word for all invasive things. Sir, Purushottam sir.
Nothing. As Shanwas sir rightly pointed out, you need to consider a use of the other anticonvulsants. The intractable uncontrolled seizures better try that. Sodium valproate is one which is likely to work. Time tested one. You do an LFT because in a below 1-year-old child, sodium valproate you reserve. For an 8-year-old child, it's worth trying from 20 maybe up to 40 milligram per kg of sodium valproate. And a feeding problem, there is no drooling in this case. But something
So,
drooling is not there.
Not drooling. Drooling.
You said there is a cerebral palsy, exaggerated jaw jerk, and the other reflex is there, but the drooling was not there.
Yes.
So in the case it is needed, you can do the trial with the clonazepam also. Sodium valproate and clonazepam, I think it's worth a trial rather than increasing the dose of this levetiracetam. So that may work. Okay. My experience, my impression was a rectal biopsy rather than skin biopsy in this case. That was my memory. Anyway, as Shanwas sir said, all the invasive things are replaced by the newer genetic diagnosis. What about the MRI finding and the genetic thing result available, or is it?
MRI findings diffuse cerebral atrophy with posterior parietal occipital white matter involved.
Picture and report. Where is the picture and report?
Picture was not available.
Okay, we are interested to see. The neurodegenerative disorders, Kunju sir must be having many of these sample pictures of all these.
MRI actually taken 1.5 years back. For the present admission, they were admitted for LRTA.
So what about the genetic study? What was the genetic material study?
It came as like red-like syndrome.
Hey, that was previous. It was now last is
epileptic one. Yes. CDKL5.
Actually, when you present like this, you should have final how you have reached the diagnosis, the sequence. You should show. The reason so many other persons are seeing, they will be very much interested in knowing what is that.
Try steroid trial with monthly ones or otherwise. Epileptic encephalopathy is not an MRI diagnosis.
Epileptic encephalopathy is genetic study.
Genetic study. Some of the epileptic encephalopathy genetic clue is the is it a which is responding to steroids or any other drug trial?
No, steroids not tried actually.
So what are the drugs that are used for intractable epilepsy other than protein anticonvulsant? Nowadays, what are the drugs?
Steroids can be tried.
IV methylprednisolone, high dose IV methylprednisolone, that is usually they used to give. Then
Epileptic surgery in refractory cases.
IVIG, intravenous.
IVIG.
Before that,
Right.
biotin, some of them respond to vitamin B12,
Pyridoxine.
pyridoxine.
Spiridoxine, then ketotic diet.
Ketotic diet.
So the latest addition to that intractable epilepsy is rituximab. So in our SAT, there are at least nearly in the last 3 months, at least 3 patients has received rituximab and was doing very well. All the patients are almost free of seizures. So rituximab is the latest addition. Immunosuppression is a mode of treatment nowadays.
In this
Just
case, it's worth a trial. Any of these things, modulators, maybe even can begin with the methylprednisolone, maybe initial followed by monthly pulse. Some of them works.
So Susie madam, the mentor, you want to add something, you can.
Sir, nothing more to add because it's a long case which is kept for the PG exam. The usual dilemma is
Susie, show yourself. Lot of PG students would like to see you. Three smart intensivist not the PGs outside SAT knows you. അത്ര എന്തെല്ലാം കാര്യങ്ങൾ ചെയ്തിരിക്കുന്നു, പല പല കാര്യങ്ങളൊക്കെ ചെയ്തിട്ട് ആരും അറിയാതിന്റെ പുറകിലിരിക്കുന്ന ഇതാണ് ഡോക്ടർ സൂസി. SAT hospital. It's a team of Dr. Shrijas.
Now madam is in TDMC.
Now I'm transferred to TDMC, sir, for the past 2 months.
Okay.
Nothing to add more, sir, because there's a usual issue with the cerebral palsy and the neurodegenerative disease. So this is because the usual question will be that because this is not a case of a neuroregression which had a normal development and normal milestones and suddenly regressing. So you had heard the history that it started with a slow attainment of milestones, and already discussions were done like in order to tell it as a neurodegenerative disease, you should have regression of the attained milestones and it has to be progressive. So this is actually, he told like Kiran was telling, he presented it well. Like from 45 days, social smile was there. But following that, he had a seizure. Then again, till 1.5 months was remaining stable. And at 1.5 years, there was a seizure and then the child regressed. So that is the issue there. So questions will be pertaining like, Kiran, I'm asking you, like, could it be a cerebral palsy? It's a static disorder. And are there any mechanisms in which the cerebral palsy child can show a regression-like features? That is what already discussed, what is called as pseudo-regression. Can you tell me?
Uncontrolled seizure can be cause a problem, or repeated infections, malnutrition, CP, and severe contraction.
Yeah. Then anything else? You have already told, few of them you have already told, because already it's a cerebral palsy child with recurrent infection. So any chronic infections can cause a regression. Second is the, cerebral palsy is a disorder of posture and tone and postural and movement. So as you are told, even spasticity, increasing spasticity, contracture, all of them will also cause regression, but that will be main pertaining to the gross motor domain. Then, the cerebral palsy children can also have, the typical evolution of spastic CP. It's from the hypotonic to the spastic, and then, by after 1 year or 2 years, they will develop extrapyramidal features also. So that extrapyramidal features of dystonia and choreoathetosis, that will again make it like it is regressive. And another thing is like about the vision and hearing. We have to be very careful because there is a deterioration of the vision and hearing also. The static encephalopathy can regress. So that is in fact a part of what is called a pseudo regression. So that will be the question which will be asked. And one more thing, like what is the importance of the family history? Because I have seen a couple of children who means like it was like a static encephalopathy, but when we probed into the family history, we could get some positive points. Can you tell me a few things, Kiran?
IEM, certain autosomal recessive storage disorders and organ family.
Not like family history. See, when I have seen like you would ask for consanguinity, definitely autosomal recessive ones.
Blood poison.
Not that, like affected siblings will be there. And you ask for the elder child, might be the elder child is also like branded as a CP. Understand? So that can be a catch. So that means, yeah. So family, the sibling is also having similar neurological problems. So that is a catch. And you can also, yeah. So that you have to be very careful. So, and you know about the CP mimickers, so that I didn't tell about it, but still for completion's sake, what are the mimickers, CP mimickers?
Felices Mensmith.
Yeah, that you can actually, how
Glutaric
can
acid.
you, like in the spastic form?
Glutaric
Spastic,
acid.
yeah, spastic form, the most prominent thing is the arginase deficiency, urea cycle defect. And then you get the metachromatic leukodystrophy. So that is mainly seen in the spastic variety. What about any other varieties, you know, like choreothetoid forms? Glutaric aciduria comes under what form?
Discard.
Yeah, it doesn't come under the spastic form. It
Spastic.
comes under the dyskinetic. Okay. Then you were telling about the seizure type, like it was myoclonic seizures. So any other catch for a myoclonic seizure in a neuroregression in a child? Might be it is at a little bit older child. Myoclonic seizures and neuroregression, which is a neurodegenerative disorder which has myoclonic seizures, cognitive impairment, behavioral abnormalities.
NCL.
No. Associated with an infection. Can't hear me.
Measles, SSP.
Yeah. So SSP has to be not in this child I was telling, because you were telling the seizure type was myoclonic. So SSP is also a neurodegenerative disorder. And you know the phases of SSP, isn't it? Which phase you get the myoclonic seizures?
Phase 3.
Yeah. How many phases? Just for the completion's sake.
4 phases.
Yeah. Phase 1 or stage 1? Is it easy to recognize the stage 1? Stage 1 usually goes unnoticed. Okay, so the patient will have just behavioral problems like cognitive decline, irritability, and it usually goes unnoticed, the phase 1. And once it comes to the phase 2, it's characterized by the typical myoclonic seizures. And by the time it is phase 3, the patient will develop choreothetoid and dystonic movements. And ultimately in phase 4, because of the brainstem involvement and the cardiorespiratory center, and ultimately death. So that is your SSP. How are you going to diagnose that? The
Measles
diagnostic
and
criteria?
EEG floods will be there. Measles antibody in CSF.
It's not PLETs actually in the EEG. What you get actually? You get periodic.
Periodic lateralized.
No. Periodic lateralizing is for which infection? PLETs are for?
No.
Yeah, it's for herpes virus infection, herpes encephalitis. So here you get periodic discharges, but they are actually high amplitude and low frequency. Okay, so they are the typical appearance. And anything else? Investigation?
CSF titer, I think.
Yeah. So CSF demonstration of measles IgM antibody. Okay. So, and one more thing, like what are the treatable causes of neuroregression? So that we are always bothered about treatable causes, isn't it? So if the examiner is asking me about the treatable causes of neuroregression, can you name a few?
Biotin responsive conditions.
Yeah.
Lead poisoning, HIV
Yeah.
encephalopathy,
Okay,
Wilson.
Okay. Then any nutritional you are already told.
B12
Yeah, we recently had a child during COVID pandemic who presented with neuro regression, and when we probed into the history, actually, we picked it up like it was having a anemia, and the MCV was high, and peripheral smear showed a dimorphic pattern. We sent the vitamin B12 folic acid, B12 came as low, and further probing into the history revealed that the mother was a pure vegan. So that was a vitamin B12 associated neuroregression. And then already Purushothaman sir was telling about the lead poisoning. You told about lead poisoning. Then you were telling about the Segawa, DOPA responsive. Okay, so that is, and biotinase deficiency. Biotinase deficiency is also responding to your biotin. Biotinase deficiency has got a similar appearance to what? Can you tell me? Biotinase deficiency is characterized by, in the head-to-foot examination,
Seborrheic dermatitis, alopecia.
Yeah, alopecia, and moreover, it's a skin lesion, eczematous skin lesion. Okay, I think that's all.
Okay, thank you, so, madam. Jaram sir. Jaram sir, കണ്ടിട്ട് കുറെ നാളായല്ലോ.
സാറേ പ്രത്യേകിച്ച് ആഡ് ചെയ്യാനൊന്നുമില്ല. നല്ല ഡിസ്കഷൻ ആയിരുന്നു, പ്രസന്റേഷൻ നല്ലായിരുന്നു. ക്ലിനിക്കൽ എക്സാമിനേഷനിൽ കുറച്ചും കൂടി പോയിന്റ്സ് ആഡ് ചെയ്യായിരുന്നു. കൂടുതലും സാറ് ചൂണ്ടിക്കാണിച്ച പോലെ തന്നെ ഡിഫോമിറ്റീസിന്റെ ഭാഗം പൊതുവെ ഇവര് സ്പെസിഫൈ ചെയ്യുന്ന കുറവായിരുന്നു. അത് കുറച്ച് കുറവായിരുന്നു. തമ്പിന്റെ പോസ്റ്റർ മറ്റു സാധനങ്ങളൊന്നും പറഞ്ഞിട്ടുണ്ടായിരുന്നില്ല. Otherwise, it was a good presentation and a good discussion.
Okay. Purushothaman sir, finish ചെയ്താലോ?
I don't know. You presented very well, and discussion also.
Thanks.
Good discussion, Arun.
Okay, so we are finished in time also, 9 o'clock. We have reached the end. Thank you very much. So, thank you, Kiran.
Thank you, sir.
Purushothaman sir, Madam Jayaram sir. Okay, so we'll wind up. Good night.
Good night, sir. Thank you, sir.
Good night. Bye.